preoperative SABR in glioblastoma multiforme, when the problem is always the maximum safe resection. So how we do high dose and then surgery. It's all about the margin. This is the first question. The second question by question, okay.
Okay. Yes, so that's a very good question, and I had the same question for you. So the rationale, number one, is to understand the microenvironment. So there's a research aspect to it, is to remove the tissue after doing the radiation and seeing what's happening to it. The other thing is that there is still an idea that maybe at the time of surgery there's some benefit to doing the radiation when it's still confined. It's a research question. I would certainly not do it off of trial, and hopefully we have that answer. Personally, I'm not that excited about it. The post-operative SABR is interesting because the goal there is to do nuclear medicine-directed CTV delineation. So hopefully we're doing better CTV delineation, therefore we can get a better targeted dose. So that may be a rationale.
Second question, do you have any experience with immunotherapy with SABR? Because in immunotherapy we have something called pseudoprogression. So how do you evaluate the response when you give
whether it's realistic?
Excellent question, and it's a question that we wrestle with very much. Many of our brain metastases patients have some sort of immunotherapy these days, and afterwards it's not unusual that we do see the tumor act up and cause edema. Oftentimes we'll just sit tight and wait and see what happens. Worst case scenario, surgeons go in and take it out and then establish diagnosis. We will use some sort of advanced imaging to try and understand what's going on. We do a lot of diffusion imaging these days, but I think it's not 100%, but realistically, oftentimes we'll just kind of see it settle down. But it is a problem, I agree.
May I ask Dr. Kimberly? We see now many patients with only sternal metastasis. I want to know your experience with this.
Yeah, I think the sternal metastasis site is, are you talking about de novo, like at presentation, or later on, or both?
I mean the prevalence. Do you see them so much, or very rare, or what? Because we're seeing sternal metastasis only, very much.
واحنا كمان على فكرة.
It is a more common site. It makes me wonder if it's because the vascular supply is so close. In some circumstances, I've wondered, is it an internal mammary node that's grown into the sternum? But I think the sternum and anterior mediastinum, if it's a limited disease, is actually a unique location for metastatic sites of breast cancer, and one where if that is a de novo presentation or the first presentation for breast cancer, there's actually a little bit of data
وساعات على فكرة وزن أقل من سنة.
patients who are treated with more aggressive approaches do better than patients who are treated with pure palliative intent. So we do sometimes treat those patients more aggressively if it's safe to do so.
I have one question.
ايه level الaggressiveness بتاعكم؟
13 metastases in the brain. 13 brain metastases. You showed us a slide with 13. The maximum number 13. You do 13 or more.
We've done more in some cases, depending on the disease directly, but I don't remember the highest number. But okay, Dr. Mahayan can tell you how many that she has treated.
And the spine.
In the spine?
So in the brain and in the spine. How many maximum bone metastasis you do sever from the spine, and how many brain metastasis you do sterilize?
So for the spine, together,
yes.
One shot. So we've done multiple vertebral bodies separate, and we don't try to do, if they are next to each other, we do, I think I forgot to mention about no more than 2 or 3 vertebral bodies, because now your immobilization and the curvature of the spine might change fracture to fracture. So sometimes it's very difficult to do that registration to make sure that the dose to the spine is safe. So we've done many vertebral bodies at the same time, 2 or 3 in different levels. So now to the question about how many metastases.
So that's a good question. Typically, what happens is that you see a patient who has 5 or 10 metastases, then you do the planning MRI, you see more. So then you grab this one, you grab this one, you grab this one. I've seen up to 30. Now,
أنا اللي
30,
بلاقي بخت.
yeah, it's not ideal. And at
أنا اللي
some
بلاقي
point,
بخت.
sometimes you decide, you pick and choose. Sometimes you say, I'm going to treat the bigger ones, they'll go in systemic therapy, we can evaluate how it's going. We do. We do. I mean, sometimes if you see so many, then you just do whole brain, right? But it's become a complicated discussion now.
So I have